I see a few new faces, so thanks for coming to Peak Brain, and a few old faces, thanks for coming back. And for those of you who are new, we are a biofeedback center that operates like a personal training center, more than a doctor's office. So we do what's called brain mapping or analysis of your EEG to find performance bottlenecks. And we do a lot of mindfulness training and instruction, both privately and in groups. But most of what we do during the day is biofeedback, biofeedback on your brain called neurofeedback, where we exercise the EEG or blood flow to create performance changes in your brain. So today's topic, we do these free brain health talks. During the day we charge you for neurofeedback, during the evening we don't charge you for anything else. So we have at least once a month a brain health talk. This one is the intro talk. And we also have mindfulness groups every Monday night that are without charge in this room. Sean will lead those groups for us. 7:30 to 8:30 roughly Mondays. Super low key, no chanting, no incense, nothing to believe, just basic technique. So if you need some practice in mindfulness, Sean will teach basic technique and give you some opportunity to practice with a small group of people. And then most of our clients come in for neurofeedback, which is brain training. They come about 40 times in about 3 months for an initial chunk of training. We can usually eliminate a lot of the performance bottlenecks people are experiencing. And so I wanted to dig into some of the history, the foundation, how this stuff is discovered, where it comes from, and give people who know about it a little more deep understanding of where it came from. And those of you who are brand new, you've got a really nice overview, hopefully, too. And please feel free to stop me, ask questions, unpack things. I sometimes forget what people do and don't know. So sing out if you have any questions. First of all, this is an area of EEG. We're doing brain recordings of brain waves. But it's not exactly like the same kind of EEG you might do to detect seizures or apnea or something at night. The biggest difference is while we're recording your brain waves, the electricity your brain generates, the analysis of it is really driven by how different you are from average. And by average, I mean the average age, or the average at your age. The brain changes throughout the life course, a fair amount. The EEG, the speeds and amounts of your brain waves don't change all that much between ages 25 and about 65. They're relatively stable. And even before that, up to age 25 and after 65, they do change with age and they cohere fairly well. So if you do an age-normed comparison, you can see how weird you are compared to other people your age in things like the amount of brain waves, the connectivity patterns, the speeds of brain waves, etc. So this QEEG, quantitative EEG, the population comparison is what we're talking about. And it is stable year after year. A QEEG on Randall today, and in a year would look the same, unless he did something significant to his brain. So an injury, major medication changes, meditation that was many months long, like a practice that was new and lasted months, or neurofeedback, those will all change your resting EEG, and almost nothing else will at a high level. It's very stable. You change day to day, of course, but your mean does not change the population mean very much. Some days you're tired, awake, alert, but you're averagely about the same compared to the average person your age day to day.
Can I jump into the question?
Yeah.
So the actual quality of the recording, a resting EEG that's done on someone who's in optimum condition versus someone who's maybe in acute anxiety, would those two look really different?
They would not. So the question is, would the states affect the EEG? And the answer is not really. You need a very, very acute state to see it in a resting pattern. You mostly see traits, you see resources. I can't tell what you're feeling right now, but I might see a tendency towards anxiety, could show up. I can say, oh, here's a marker which means your posterior cingulate is more active than average. Most people experience that as an enhanced threat response and evaluator. Things in the sort of PTSD direction, perhaps. If you're like, that sounds like me, I'm always checked in, I can't not notice everything, and we see the marker, then we believe it's significant. But you could be experiencing tons of anxiety, it would show up. No acute anxiety, but having a tendency to, it would show up exactly the same. Some things do show up as acute events, but those have to be very, very extreme things in the brain to show up in real time. If you fall asleep or have a seizure, you see it in the brain activity right away. But otherwise, it's very 10,000-foot view stuff. And because of that, it's a prognostic. It's a hypothesis generator, not a diagnostic test. So this is closer to like functional medicine than true medicine in some ways, looking at shapes and patterns, trying to find the outliers and going, this one paper said this thing is unusual, and you try to help your clients understand where the weird things in their brain are, like a personal trainer might. Again, hey, this is unusual, not like a doctor will, this is true. I joke now that you hire a doctor to tell you what they know, and you hire a scientist to tell you what they don't know. And so I'm mostly asking questions, not giving you answers, actually. Yes, sorry.
You mentioned medications.
Yeah.
Do medical medications like lansoprazole or Synthroid?
Dramatic
or those?
effects from most medications. Yeah, psychostimulants, anxiolytics, benzos, opiates, major effects in the EEG for 5 half-lives. SSRIs and other blood level drugs, while there is an effect, it's not an acute effect. You can't really see it in any dramatic way, usually. But caffeine, dramatic effect. So you have to have people abstain from caffeine from 4 p.m. the day before their mapping day. And they map in the morning. So again, 18-hour clearance, that's something like 4 half-lives. You're mostly clear of the caffeine effects, but not in withdrawal yet, which is a lifestyle issue for most people. So you can get that sweet spot where it's not actively distorting your brain, but not also leaving you in weird states. So we call the things we find in the brain maps discriminants or biomarkers, and these are sort of statistical patterns. Here's one that's unusual for the population, and it might mean this. The most valid, the most reliable one in the data is the theta-beta ratio. Theta-beta ratio suggests executive function difficulty when it's high theta over beta. Having lots of theta means the brakes are off. It's squirrel, that's high theta. Things pull your attention, you can't inhibit, essentially. So the ratio of theta is high relative to beta, you can't inhibit, you can't concentrate through distractions. We often call it ADHD or impulsivity. And it can also show up with aging. You have increased ratios with aging issues. Another aging thing is the speed of your brain, the peak frequencies, the average frequencies of your brain waves. So I can look at how fast your resting frequency, your alpha waves are, and determine if your brain is essentially appropriately aged. If you're aging faster than you should, because of wear and tear or stress or just normal aging, your alpha waves will be slower than they should be for people your age. And if they're more than a standard deviation slower than average, I would expect it's getting in the way. And I would say, oh, with this slowed alpha, people have some slowed processing, and usually in the afternoon they experience word finding issues and naming issues and short-term sort of memory blips. Is that true for you? Oh, it is? This slowed alpha is probably related. We can now go after it, we know where it is. Oh, it's not an issue for you? This slowed alpha might be normal for you, typical for you, it's fine. Let's move on. And I go through about 30 markers in the data and try to figure out which one of these things are actually valid for you and which one's not just valid, but important to work on. And that's the difference between a coach and a doctor in this role for me, is I don't tell you what you should work on or what's wrong. My job is to demystify your data and then say, and what do you want to work on? What's important to you? Stress, sleep, mood, attention. We're seeing some bottlenecks. What do you want to work on? Just like a personal trainer asks the athlete what their goals are and then executes the program for them, they don't set the goals for the athlete. And that's really how we work. Even if it's diagnosable, labeled things, I'm always dropping one level below the label and trying to find the brain resource the person wants to work on. So this was discovered in 1967 at UCLA on cats. Cats are very bad instruction followers. This is not a voluntary process. This one slide, the next couple of slides, answer the question about placebo. There is no placebo effect in cats. They do not understand what you want them to do. My cat does, she's very intelligent, but most cats don't understand things. So in '67, Sterman was approached by NASA. Sterman was doing lots of learning studies at UCLA. And I think a colleague of his left the university, and NASA had some funds in the department they wanted to spend. So they said, hey, look, can you please examine how dangerous rocket fuel is? Because our astronauts are getting sick in the capsules. They're nauseated, they're hallucinating. What's going on? Let's figure out how dangerous this stuff is. So Sterman is a learning behavioral scientist. So he took the cats, made an airtight plexiglass cage, put a beaker of rocket fuel inside the cage, put the cat in the cage and closed the door and started a timer. It was the 60s. We're doing a lot more aggressive animal research back then. But all the cats were eventually crying, drooling, stumbling, and vomiting. And some of the cats, most of them, had seizures as well at a certain point. What he couldn't figure out is of the 32 cats he was using, most of them had this perfect dose-dependent curve. And this is a sanitized slide: vomiting, crying, panting, sobbing, seizure, coma, death, is what he used to say. And the line just continued, this line here, for 24 of the 32 cats, roughly. But some of the cats refused to have seizures. They needed 140 minutes of exposure to the methylhydrazine to show any instability events, instead of showing seizures at the same period of time. And you couldn't figure out, wait a minute, why is 1/4 of my subject pool seizure resistant? This doesn't make sense. Until he remembered he'd used these same cats in another experiment 6 months prior, to see if you can train up a brainwave whenever you squirted chicken broth into their mouth as a reward. So you measure a brainwave cats make a lot of. If you've seen cats lying on a windowsill watching birds, you've seen this brainwave. That liquid body with laser-like focus when they see a prey animal. Predators drop the tension in their body when they see prey animals because you can leap into action much more rapidly from relaxation than from tension. So that combination of alert mind and soft body is a special state that some animals go into, and humans can too. We don't use it the same way. It's called SMR, sensory motor rhythm. But that liquid body and laser-like focus is the opposite of ADHD. Literally the opposite of ADHD, where you're motorically hyperactive and mentally a little bit distracted. So you can train up SMR in humans and eliminate ADHD or seizures. Sturman's lab manager was a medication uncontrolled epileptic. This is her seizure log with tens of seizures per number, so 30, 40, 50 seizures here. And we do this much faster now, but he built her machine. She weaned off all of her meds and then had reduced seizure, remained seizure-free. We can now do this kind of change in about 3 to 6 months instead of a couple of years. But this is a pretty classic case. This is one of the first ones, of course. And then in 2000, Sturman published a review article. There's been more papers since, but in 2000, the state of the research was 82% of the studies showed, 82% of the subjects showed a significant drop in seizures, more than 30%, with the average more than 50%, and 5% of people have complete control of seizures for more than a year. And this is like a 20 to 30 session course of neurofeedback, so like 30 half-hour sessions of training can eliminate seizures for a long time. A very robust effect. This is involuntary. Cats aren't deciding to have seizure or not. This just happens, right? So from epilepsy, from seizure, we then moved into ADHD, sleep, which is also an SMR. In humans, SMR is called sigma, or sleep spindles. In animals, we call it SMR because it's an active frequency. Humans don't make a lot of it when we're awake, except inhibiting seizures and keeping the brain stable. But predators use it as another level to sort of soften their body. But humans, it keeps you asleep. Sleep spindles. It also causes memory formation in the hippocampus. It triggers ripples of memory formation to cause this tissue to create memories, essentially. So why does it work that we can actually make these changes? Well, essentially the brain's already changing. And my joke here is that shift happens. You might as well take control of it. It's going to change. So it's not a question of if your brain is changing, it's how. And it's going to pattern itself against these stressors, challenges, pleasures, pain, privations that you experience, and it's going to learn to minimize those pains and maximize the gain, the pleasure, the reward. And so if it's already going to functionally adapt, you might as well take control of that process. And this is based on what we call Hebbian plasticity circuits, that where cells that fire together become more likely to fire together over time. So you take disparate, disconnected circuits and kind of wire them together by making them behave at the same time. So essentially practice. The difference in neurofeedback is the practice is involuntary. We practice you instead of you practicing you. It's kind of a strange experience. So getting back to the mapping process, the assessment, this came after neurofeedback. So Sturman discovered neurofeedback. EEGs were already being done before that, but this idea of doing population database comparisons was a newish thing. And in the 70s, several people actually pursued this as a medication selector. And you can actually tell, based on the EEG changes, what will happen on medication weeks later. So the something on my dissertation committee, Dr. Andrew Luchter, Andy has an EEG measure that 1 week after you start an antidepressant, you can tell if it's going to work in 3 or 4 weeks. And in depression clinical work, you have to cycle with 3 medications often, 3 medications to find one's going to work. It takes 5, 6, 7 weeks to work. You might spend a lot of time clinically unstable while you're finding things that work. So Luchter can measure your brain a week on a med and go, yep, it's going to work in 2 weeks or 3 weeks. It's a huge clinical benefit. This is the guy that taught me EEG, Jack Johnstone, who died a couple of years ago. And Jack thinks about the EEG as phenotypes, not diagnostic discriminants. Discriminants have failed, finding the ADHD marker, the anxiety marker, this marker. A lot of research has been done on those things, or Suffin and Emery, 2 great researchers looking at medication responses. All the discriminants are a little weak. The most valid is ADHD at 94%. It's not that valid. And that's the best one. So Jack, Dr. Johnstone, always got me to think about one level below the diagnostic label. And you find patterns across diagnostic boundaries, but that are of functional significance. And there's about 10 or 20 of these things. You can kind of dig in and figure out which ones are operating in which ways for different people and describe their resource limits to them, which is kind of shocking to say. You experiencing this? Wow, how did you know that? Because you can see some of these things. Here are some of the more reliable discriminants that we look for. Theta-beta ratios is the most valid. Also based on the work of Richie Davidson, who's a long-term meditator, psychologist. Frontal asymmetry is a marker of depression. When the left is less active than it should be and the right front is more active than it should be, you have frontal asymmetry. And that is about, how much of the literature says, my experience about 2/3 of the time when I see a frontal asymmetry, I get a complaint of depression. It's not a super valid one, but it does show up often. Also, eyes closed frequencies. When you shut your eyes down, close your eyes, most of the cortex that's doing fast processing things will actually relax. So the visual system is a huge swath of tissue in the back of the head. The whole sensory system is back there. When you close your eyes, most of us go quiescent and produce alpha waves in the back of the head. Unless you're hypervigilant, your brain's like doing this and won't let go. When you close your eyes, you see a lot of red in the back of the head, high amounts of beta waves. The opposite can be true. You open your eyes open, and you don't suppress the alpha back there. It stays lit up when you open your eyes. We call that inattention, or ADD, which is not a diagnostic label.
Is that also a lot of creativity?
I'm sorry?
Is that also a lot of creativity?
No, eyes open alpha is inattention and spaciness.
Okay.
Good access to theta is creativity. 6.5 hertz is memory access, we think. But if theta is high, eyes open, you're not creative, you're impulsive. So it's about state trait matching here. So creativity, you can train up creativity. The way you do it is you train up the hypnagogic state between awake and asleep. That involves bringing theta and alpha both up. You get a certain depth into it, alpha drops away, theta surges, and you have what's called a crossover, a flow state where ideas, emotions, visions, insights, it's bubbling up. It's that liminal hypnagogic state. You hold someone there for 25 minutes at a time. You never have access to that kind of information usually. And so it can be amazing if you're not in touch with yourself, or you want creativity. It can be horrible if you're traumatized and you have anxiety lurking just below the surface. So you want to do alpha theta, which is this technique, but you practice it, you get that generative wellspring access. You aren't then stuck in that mode eyes open. You don't see high theta, but you reach for that wellspring and it just opens up voluntarily. So the traits change, but you don't always see them in the brain maps because they aren't stuck resources. Other things you might see with betas, there's switching systems, anterior cingulate, posterior cingulate, for what's important to pay attention to and what's necessary to pay attention to. This is like value, and this is like danger, essentially. So if you're driving a car and you stop watching the road, the little guy back here will throw a flag on the plane and say, "What are you doing? Watch the road." You know, and the front person, if this little circuit's overactive, you get stuck on things. Stuck in your head, little OCD, such the switcher and the evaluator. Anterior, posterior cingulate, when those are high with eyes closed, we get obsessions, and we get fear-driven rumination. So you can kind of predict OCD and PTSD category things a little bit, or hints of that. So, I already mentioned the peak frequency. If alpha slows down, your processing speed is slowed down. If that's associated with age, I would guess that you're aging fast. Maybe it's associated with lack of deep sleep. You aren't getting enough sleep. And I see that as a high delta wave when your eyes are open. Maybe we see that with brain injuries, lots of wear and tear producing changes in connectivity, where I would do a 2 database comparison, typical people and concussed people, and plot your connectivity changes between those two curves and see how likely it is you've had some wear and tear. I wouldn't say, oh, damage, but I'd say your connectivity patterns are unusual and statistically plausible like an injury pattern. Any injuries? If you're like, no, I've never hit my head, ever in my entire life, well, first, you're probably wrong. But second, I would go, great. This might just be lack of deep sleep, because it's the same marker. It blows up into a statistical sort of mess sometimes. Lack of deep sleep, injuries can look the same, so I don't necessarily tell them apart. Again, I ask questions. I don't tell you what's true, I just ask the right questions. All right, that's what's on this page. Oh, here's some studies. I have several studies sorted. Pritchett, John. This is subtyping different disorders. So many people have subtyped ADHD into ADD, into oppositional stuff using EEG. It's really reliable. OCD is pretty reliable. Anxiety is reliable. You can also look at populations of interest, like cocaine abusers, and sort those who will relapse and those who won't into statistical buckets reliably. Or ADHD, thousands of brains statistically, and say, yep, ADHD, non-ADHD. That's 94% accurate. Suffer and Emery have EEG response to meds, and of course Andy Luchter has that 1 week antidepressant response as well. Andy is the big placebo guy, Dr. Luchter. Placebo is his big research area. He also runs the STAR-D study for all the antidepressant arms for all the big insurance companies, med companies. This is him. So this is not a low-key researcher. Very humble guy, though. So mood, Rich Davidson, state and trait, frontal asymmetry. Also some folks at Wisconsin with Davidson looking at reactive temperament, like how easily you're made anxious or upset. Other studies, Hughes and John, show the same kind of frontal asymmetry tends to show up in the data. It's not a very robust effect. But David himself has said it's actually not frontal asymmetry recently. He said it's more about general brain asymmetry. But neurofeedbackers latched onto the first things he found, and we think about frontal asymmetry as a valid resource. It's probably not exactly valid for mood, but it's somewhat informative. For ADHD, Chabot and Serfontein, 94% specificity for sorting. Manastro, this is the big study, 94%. Mon was only 80%, sorry. And then subtyping, ADHD versus ADD essentially, or PI versions. I'm talking about attention a lot in the context of brain mapping because we often consider executive function a core resource, even if ADHD isn't your problem. You might see executive function, self-control, impulsivity, inattention, resource limits show up as a function of other things. You have a concussion, you might be impulsive. You have a concussion, you might be inattentive. You're not sleeping, you might be either. You have anxiety, you might be impulsive or reactive. So I'm really trying not to believe the labels people are walking in with and try to figure out which of the resources are actually a bit distorted in their brain and help them understand their physiology, not their mind. My job is to help you, assess the machine more than the experience of the machine. But I do look for attention broadly. It's also the most reliable marker we have, so it's very robust to spot for people. Here's an example of a brain map. These are population comparisons. This is the bell curve of how this person differs from typical. And we have brain waves in columns, delta, theta, alpha, beta, high beta, slow through fast brain waves. This person was making 3 standard deviations more than they should have, more than average anyways, more than typical, of the slow brain waves, delta, and theta. Now this is an eyes closed map. I just happen to know when they open their eyes, this actually goes even higher, which is a brain fog and impulsivity kind of signature. But with eyes closed, we see the anterior cingulate lit up in fast frequencies. This is that switcher. So this person has a lot of stuff stuck in their head. They're inflexible, they ruminate. This person's actual OCD. And then with their eyes closed, the visual system is staying lit up in the back of the head. That's the hypervigilance. So this person had a brain injury with a lot of brain fog and left with a lot of ruminative anxiety and hypervigilance, but they didn't feel very sharp. So they ramped themselves up into anxiety to overcome a low-key brain injury. Here's somebody else. This is a classic case of ADHD, high theta, ADD, high alpha, stuck in neutral. However, left front alpha and right front beta is that reversal we talked about. That's major depression and the little rumination marker. This guy was profoundly OCD, major depressed, and the worst ADHD case I've ever seen. And he also was drinking all of the alcohol and smoking all the weed he could find. Miserable guy and ridiculously impulsive and just miserable and bitter and angry and couldn't get out of his own way. Kicked out of his house, his school, his relationships. And he was abusing substances. I met him too. And this is his brain after 30 sessions of neurofeedback. Same guy. So
Same drug, alcohol use?
no, he actually he stopped drinking alcohol a month before this first one. And I don't think he was doing cannabis. He's since doing lots of cannabis. He actually I saw him recently. For the past 2 years, he's held down a job at a cannabis shop. His mom's not super excited, but he's fine with it. He's back in school in his master's program and everything else.
How did you keep him motivated or get him motivated to do this?
Well,
those sorts of people aren't terribly compliant or motivated.
But you don't have to do anything beyond show up and effects happen. So once you get that sense of agency, I showed up for 2 weeks, once for half an hour, and wait a minute, I'm feeling better. It's really easy once you get over that first 2 weeks. So teenagers that want to be here love it after 2 weeks. Alcoholics, once they realize they can fall asleep at will with no alcohol 2 weeks in, they're sold. So effects start showing up 2-3 weeks in for most people. And they're interesting enough to go, wait a minute, this is kind of cool. Kind of like the first time you ever hit the gym for 3 weeks straight, you're like, ooh, I feel kind of balanced, and I'm sleeping better. All the same things happen as if you're working your brain out for body changes too. It's sort of broad stuff creeps in and you enjoy it. Here's somebody else. This is an alcoholic, or was an alcoholic. Extra beta, fast beta brainwaves. This is connectivity, coherence it's called, but it's connectivity. This guy was 3 standard deviations over-connected and 3 standard deviations high amplitude in the fast brainwaves, low amounts of slow, and under-connected to slow. if you've met any long-term chronic alcoholics, you've met people like this. The shaky, nervous, can't settle down, distract themselves, like anxious, ADHD, cannot fall asleep without a drink. This is what you see every time. And this guy was 25 years of a bottle and a half of wine, and Ativan, and an Ambien every single day. And he would get 2 hours of sleep. When the meds wore off, he'd find himself wandering around his neighborhood, having fallen down the stairs, wearing his underwear, bloody, because he was just disoriented. Unusually for an alcoholic, he did not crave alcohol in the slightest. It was 25 years of sitting in, he was a writer, sat on a beach, just wrote with alcohol in his hand for years. He was habituated to it, didn't crave it in the absence of alcohol, didn't like it actually, from what he said, but he did not fall asleep 3, 4, 5, 6 days in a row, no sleep unless he drank alcohol. So he was using it at that, but he was also in liver failure, 6'5", 350-pound Oompa Loompa looking guy. And his doctor was like, look, your last drink is your next drink's probably your last, so you might want to think about making some changes. And he came to see me. He said, yeah, I have an alcohol problem, but I'm actually okay with that. I have a sleep problem. I need that help with that. I can sort my alcohol out. I have no problem abstaining. I just have problems not sleeping. And that's what this shows in the literature. It's a very classic pattern. This is his brain after doing 3 months of training. So we had 3.5 standard deviations of change in 3 months, permanently. I saw him a year later, he was fine. He was sober, he was holding his life down, he was sleeping. 2 weeks into this process, he was coming to the office and going to sleep on the couch. Oh, he's sleeping on the couch again. Is he here for a visit? No, he's just proving he can go to sleep. So people do that stuff sometimes. So what is this neurofeedback? How are we making these changes? By training, by exercising brainwave or blood flow, broadly. Unlike body-based biofeedback, heart rate variability, skin, hand warming, stuff like that, central biofeedback is involuntary. You can't control your brainwaves or your blood flow. You can control your heartbeat and your hand warming. You can learn to control those things. So in peripheral biofeedback, you must keep practicing till you learn it. You can do it voluntarily. In central biofeedback, you do enough of it until the brain takes over the new resource and now it's permanent. So it's a lovely involuntary process, i.e. it works on cats and nonverbal children and people in comas and teenagers who don't want to be here. So we don't zap the brain. There are forms that do send electricity back in. We don't do that. We simply passively measure what your brain's doing on its own, moment to moment. Whenever the brain shifts in the right direction for half a second, we go, good job, brain, with audio and visual feedback. When it shifts in the wrong direction, we stop the feedback. The brain's like, hey, I was watching that Pac-Man, listen to that music, and the brain happens to shift on its own. The game goes, yep, good job. And so you get these little stops and starts of stimuli to teach your brain, yeah, more of that. Oh yes, more of that. And then you don't really experience too much in the session. Stuff stopping and starting on the screen. But then the next day, there's a tiny little shift in your resources because your brain got more input for some things it was doing for half an hour, so it does more of those things tomorrow. And then you spot any shifts in sleep, stress, mood, attention, and after a few sessions, things start to develop and you can say, oh, I'm sleeping differently, I'm attending differently, my stress is different. The way we do it is 3 months typically. We squeeze about 40 sessions into 3 months. I get pretty good permanence and I get very rapid results. I think they're probably a little more permanent, a little more rapid than most of my colleagues because I train a little more intensively. Most colleagues are therapists and will do a therapy session once a week and neurofeedback twice a week as part of their program. And I always do neurofeedback 3 times a week and have you pause the weeks you can't come in for 3 times just to get your brain moving. And then we map the brain typically 3 times in that first 3 months. At the beginning, there are 20 sessions of training. And I can usually get about 2/3 to a full standard deviation of change on attention tests and brain maps every 20 sessions. So you can often get between 2 and 3 full standard deviations in about 4 months of training, which is going from profoundly ADHD to none, or from lots and lots of seizures to the occasional seizure, or really dysregulated anxiety to anxiety that's only occasionally out of your control. And then for the big regulatory things, stress, sleep, mood, and attention, we would expect permanence, eventually. For things where there's an active disease process fighting back against your brain, it won't be permanent. Like I've done a lot of work with people who are Parkinsonian or some schizophrenics. And in both those cases, we're kind of fighting against something, and I can make lots of great effect, but when the schizophrenics stop coming, the disorder often kicks back in. The Parkinson's guys seem to have more stable effects, but I haven't worked with them over enough years to know if the aging component is going to erode the stability longer term. But I've reduced tremor and improved muscle movements and things like the joint movements a few times in Parkinson's. But other things like psychological things, depression is not a resource in the brain. I see anxiety as a switching system. I honestly, depression is a resource, so it's a human experience of a resource being pinched. We have to sometimes go after more things to make more individualized or nuanced things change. Let's see. So there's good research evidence for all of these things. And by good, I mean there's okay research evidence for all of these things. There's many reasons why the research evidence is a bit lacking, and I would say the clinical efficacy is in advance of the research backing by at least 30 or 40 years at this point. It's a massive, we were so effective, and the research doesn't really show that. There's many reasons for that. One is it's been really hard to blind EEG in a placebo sense until very recently. So you couldn't do double-blind placebo-controlled studies until a couple of years ago. Two, the process is heavily individualized. It's really hard to do large studies when the process is different, when the intervention is different for every person. Three, you have to come 40, 50, 60 times. Very expensive. At the scope of an FDA sort of clinical trial, it's at least a $5 million study. Nobody owns neurofeedback. So you can't engage the model of spending the money on the drug, developing the drug, selling the drug for lots of money. It doesn't work that way. No one owns this. So the research is always lots of little tiny, there's thousands of little tiny studies done by clinicians or one person who cares about a population. And there's like an unbelievably large number of weak studies and a few good studies. And ISNR is the trade organization, International Society for Neurofeedback and Research. And they have a comprehensive bibliography, they call it, which is a couple thousand papers across topics indexed by complaint. And on our website, we have a few of the paper abstracts outlaid, ones we think are interesting or more recent. But there's really, really, really good effect. The strongest research is for seizure, ADHD, sleep, and anxiety. Those are the low-hanging fruit for neurofeedback. So some of those are cognitive, some are not, right? Seizure's not a cognitive experience until after it happens. But anxiety is for some people. Here's an example of the process in action. We measure a brainwave, a raw brainwave off the head, filter out 3 different frequencies off the head, like theta, beta, high beta, for instance. And then when the good frequency goes up and the bad frequencies go down, here's another example. It's in a different piece of software. Raw signal, and then I'm measuring theta, 4 to 7 hertz is theta. The amount of theta the person was making was 19 microvolts at that moment, and it goes up and down all by itself. That's what your brain does. The height of the wave is the amplitude, the amount of the theta. Since you want theta generally to go down, what you do is you measure what they're making and put a cap just above it. That's called the threshold. In this case, the threshold is 23 microvolts. Person's making 19, so that's the blue lines. Whenever the theta surges, it goes up above the blue lines, and it stops the game. It goes back down, the game resumes. This is the opposite. This is low frequency beta. That one is calm focus, the SMR. So I want that one to go up, so I'm measuring 5 microvolts, put the cap just below where the person is. And now measure what they're doing moment to moment. As long as the brain stays in the right direction or trends in the right direction for half a second, we go, good job, brain, with audio and visual. And the trick is every 30 seconds or so I move the goalposts. So it's operant conditioning. You can't ever make it move voluntarily, so it stutters. One of the games might look like a spaceship flying and stopping and flying and stopping, or maybe you're a griffin flying over a lake. In this case, this is the calm focus brainwaves. You see it get bigger and smaller, bigger and smaller. And the distraction brainwave gets small, the attention brainwave gets small, and your little griffin flies towards this target in the sky. It's kind of silly, but it doesn't really matter what it is. The brain can learn from the changes. In fact, my grad work was on a simple audio beep, largely. It works fine to create a learning event in the brain. Sturman's first stuff was a simple audio, it worked fine. Doesn't really matter what the stimulus is, the brain can extract the information from the changing pattern broadly. So I've got lots more slides that are probably kind of overkill, and they're all on different complaints. So just to point out a few of these things, lots of 3, 5, and 10-year studies. The efficacy for ADHD in the literature is 80%. For us, I would say it's near perfect efficacy for ADHD. Seizure, there's so many studies, including ABA reversal studies. We can get rid of seizure and bring them back in with the neurofeedback. It was not done anymore. You can't ethically do ABA studies in humans anymore. But in the 60s and 70s, people did. And so the first studies on seizure was to reintroduce the seizures after you eliminated them. And you can, and then you can train them out again. So it's a very robust effect. Addiction, incredibly, this is among the best body of literature. It's a huge amount of literature about alpha theta. It used to be called the Ptsd protocol. Eugene Ptsd developed this. Again, puts you in a hypnagogic state between awake and asleep, and it holds you there. Alcoholics have lost access to that transition state into sleep. They can't downregulate. So you teach their brains to go there, you cause the ability to downregulate, to self-soothe, to shut your mind off. It's really rapid. And you do it without therapy or counseling. So the person who's often resistant to engaging with the cognitive stuff doesn't have to. And alcoholism is often driven by an inability to be comfortable with what you're feeling, right? Or at least that's one of the drivers of addiction, is not being comfortable in your own skin. You don't have to work through anything to get rid of the irritability of the system. You just tune it down. So sometimes people choose neurofeedback because they don't have to do therapy. It's almost like a personal trainer coming in and helping you out. Depression, again, alpha asymmetry tends to show up and get reduced. Here's a case study, many case studies for depression, but depression is very heterogeneous, very different across people, so that's why the studies are all small for depression. OCD, this is CBT therapy, cognitive behavioral therapy, is quite effective for OCD as well as for phobias. It's 51% effective in general for those who stay in treatment. Half of all people who are OCD or phobic and who do desensitization or CBT drop out of therapy because it's too painful. Those that stay in, half of them actually get really nice changes. Medication is about a third. Neurosurgery is about a third for improvements in OCD. Neurofeedback, 20 sessions, small, non-blinded trial, 85% improvements in 20 sessions. So, and you'll see this if you get into neurofeedback, is true across complaint. Our effect sizes and the efficacy is always like unbelievably high compared to the medications. A good medication is effective 50% of the time. A really good one, right? For a cognitive thing. You know, and most antidepressants are like 40% effective or something. Most psychostimulants do. You know, it's not that effective.
So did OCD get final FDA approved? I'm sorry, for OCD, didn't deep brain stimulation get final FDA approval?
DBS did, yeah.
Okay, yeah. So that's what, $50,000-$60,000?
Yeah, and causes side effects,
and
right?
I need that, I need 2 5-inch holes in my brain?
These days they've removed most of the issues of the DBS by changing the technique. All the cognitive issues that came up from DBS, so first of all, DBS was only used initially for tremor, right, for Parkinson's. Now it's used for depression, it's used for OCD, all kinds of things. But initially all of the issues with DBS were because of the surgery, because of inflammation around the metal electrodes as they went down into your cortex. They use a lot of Teflon and carbon fiber electrodes now. They're neutral to the body, don't cause inflammation. So a lot of the cognitive effects in Parkinsonian populations that happen in the first 20, 30 years of literature aren't happening now with DBS at all. And DBS is being used for other things that are invasively, behaviorally invasive, like OCD, depression, because it seems to work. But I'd probably go after like a vagus nerve stimulator before I go after a deep brain stimulation for depression or something. I'd go after some other access, because brain surgery, once you open your skull, you're never quite the same. Intelligence. I don't believe in intelligence, by the way. I don't think it's a valid measure. I think intelligence tests measure what intelligence is what intelligence tests measure. It's not a valid construct. It really isn't. And it's mostly a culturally bound construct, too. It's this weird thing where intelligence was the difference between chronological age versus developmental age. And it was developed in California as a function of how delayed you were in age against your grade level. And because of that, it was a heavily culturally referenced test initially. And there's many ways in which IQ is weak. Like our parents on the exact same test score 20 points lower than we do. The exact same test. As a cohort, that's not a function of the test being valid. It's a function of a cohort effect of aging or something. It's not a valid effect of intelligence. That being said, typically get 15 IQ points in the literature for neurofeedback. So you're seeing a change. And 15 IQ points is a full standard deviation. And I get a standard deviation of change from neurofeedback on attention testing and brain mapping like every 25 sessions. And this is pretty much about what they're seeing there. So PTSD, this is mostly alpha theta. We do a lot of work with veterans. We have a free program. You can join our program with no charge, one person at a time for veterans. It's called the Homecoming for Veterans Program, a network of neurofeedback providers. We're pretty active in it. We have a chair per office available, and we give more to the veterans than the program asks us to, but we have these kind of results where we have a hard time keeping our vets in the program and finishing it because they feel so good and they go get their lives back together. But it's very, very powerful in PTSD. I can pull the teeth of PTSD almost always quickly within a few weeks. Dissociation. Rizal did a bunch of work on creativity, and then Manchester did some work on DID. A single alpha theta neurofeedback session improved performance ratings in was it Imperial College or Royal College A single alpha theta session improved the judges' ratings of the students who received the alpha theta session. And they controlled for stage fright. They measured the student's stage fright going in and controlled for that as the factor. It wasn't the factor, it wasn't being calm. It was being more musical, having better performances. And they got 2 grades, and it went from like a C to an A or something. On average, they got a massive improvement in grade level. DID seemed to also improve. I've done a lot of work with DID in acute environments. I'm not sure how I feel about it from a brain perspective. I sort of think of DID as another form of an anxiety disorder, like a PTSD. But I'm not a psychologist, so I have to think about that too deeply. So does it work? It does, and we produce change here. This is our data, roughly 1 standard deviation in brain mapping and attention testing. Roughly 2 changes overall in 3 months. If you have much greater need, you got 3 to 4 standard deviations out of range, you'll change even more and more rapidly. The worse things are, the faster you seem to change. It's kind of nice. We start seeing the EEG change in 5 to 10 sessions. We typically map your brain again at 20 to show enough of a change to point it out to you. It's really a color shade difference on those maps, and 15 points on the attention tests often. So really big changes. Most of our clients will do 40 sessions in 3 months, take a break. And I have some clients that just never stop and just crank, and push resources. But most of our like ADHD, anxiety, sleep issue clients will do 3 or 4 months, have most of their needs met, stop, and might come back for a month or 2 in the future, nail things back down, or even chase other goals. We have a pretty aggressive referral program, so if you refer friends in who sign up, you get a free month on your program. Some of my clients come back and do more training because they can, not because they need to. Here's a recent study from last year looking across several kids showing 6-month gains that were very stable across ADHD. It's one of the most recent studies in.
And full disclosure, it's probably important to say that that European study offsets what was a negative meta-analysis in the main journal of the American.
Well,
Child
the
Health
meta-analyses
Psychiatrists.
don't make a lot of sense because most of the research is not blinded, and they're doing meta-analyses across techniques in neurofeedback. They're not the same.
Yeah.
And it's apples and oranges. The meta-analysis is not very well done. I mean, it really wasn't. And there's been several other meta-analyses on ADHD that all show positives, or OCD all show positives, seizure all show positives. When you look across many, many studies, they fail because you're combining techniques. Or because you're using, usually a study will get built by someone doing, well, let me use a single technique and try to get as much as I can from this one technique. So the techniques in the studies are super weak. If you follow case study data, they're always amazing, but studies are often a little bit weak.
Mm-hmm.
So why isn't it covered by insurance? Mostly because the research isn't there, but that's the generous explanation. There's a sort of conspiracy theory explanation here too. The day after Sturman discovered he could reduce seizures like this in cats, he sent a draft to the journal Epilepsia. The day after that, his funding was pulled by NIH. No one knows why. And for the next 15 years, all the big drug companies sent MDs and paid salaries to MDs to go to CHAD meetings and say it didn't work. So they poisoned the well. They've been poisoning the well for 50 years, aggressively. And I've been experiencing that even more recently talking to big insurance company execs. They hear Neurofeedback and they're in the field for 30 years. They have this very specific idea about it that is distorted because of things like this. But it works powerfully, and I challenge any of you to come into my office for a month and not have your minds blown. Here's a few other people. I'll show you some more data. Here's a girl before and after training. She was having a lot of hard time. 2 things show up for her: high thetas, impulsivity, lack of alpha, can't settle down, can't relax. She can't find neutral internally. Of course, her brain's quite a bit different at the bottom. But here's an academic assessment. One of our friends who's in town, who's a psychologist, did. Dr. Jim Russell did this assessment, and this is her a year before this. She's on stimulant medication here, performing 70% of grade levels this line. So most of it's below grade level, below 70%, below 2/3 to grade level. And here she is a year later, off of all meds, performing mostly above grade level. She's on heavy doses of stimulants and struggling with anxiety and ADHD and performing really poorly. A year later, she's performing incredibly well, and she feels great, and she feels confident and competent. I read a study recently looking at long-term results on self-esteem of kids who were on stimulants, neurofeedback, or both neurofeedback and stimulants. And the kids that have received neurofeedback with or without stimulants learn to have study habits, agency, and 10 years later, they're better students. The kids that just got stimulants have weird self-esteem issues from being ADHD 10 years later and never learn to study. So it doesn't actually fix the problem, it masks the impulsivity when you're a kid. Question?
So what's the bar graph as opposed to the plot points?
This here?
Yeah.
So the dots are each subject in school, or each little tested, like verbal reasoning, vocabulary, reading comprehension, writing mechanics. And then this line here is 70% line is basically grade level. And she's the dots are where she is.
What do the bars represent?
The bars represent, it's probably the mean versus the variance of the sample if I had to guess.
Oh, okay.
I'm not sure actually.
All right.
But I know she is the dots. Yeah, I'm not sure. It's probably the mean of one of the things versus the overall trend, but I'm not sure. I'll ask the guy that collected this. If it was on my test, I can explain it completely.
I was just trying to decipher.
No, you're absolutely right. Yeah, you're absolutely right. What I know to be true is the black dots are significantly higher off of medication a year later. Here's somebody else. This person received an immediate impact, and concussions often don't show up right away. They take 3 to 6 months to show up in the EEG typically. If they're really severe, you can see them right away. Concussions produce 2 different types of damage. Shear forces pull the brain apart and produce excess fast frequencies when tracks are broken. Crush damage shuts off part of the brain and it goes into like a pulse frequency of the brainstem called delta. And so this person had both. You can see the actual locus of impact right there. And she had a pretty significant loss of consciousness too. And check this out. I'm gonna go to the next slide, which is her after training. Look at the upper right-hand slide, the betas. See how they dropped? That's post, there's pre, there's post. So all the acute stuff dropped away. And then what we're seeing now is the contra Q injury months later developed. So we saw the Q, the impact, and usually there's like the brain bounces around, you see opposite corners, which you'll see months later, but I saw her immediately and didn't see the contra Q until months later. But we also shut down, if you look at the frequency, the connectivity, this is brain fog stuff for her, dramatic. And so is all the delta, but this is a sign that her wasn't sleeping, she was really foggy, it's connectivity. Blue means you're low, so it's chaotic waves, underconnected. And when I go to the next page, you'll see what happened after training. We got rid of most of the coherence issues. We left, we didn't do a lot of training, 30 sessions, I think, yeah, in only 6 weeks. But in 6 weeks, we shut down the vast majority of brain fog for her subjectively, which was great, and she was sleeping better. And then we got another sense of her brain. Now we can go after this stuff. And that is the last slide I had. So some more information. Here's our website. Here's our social media. Here's the ISNR bibliography if you want to go dig in. We have a lot of those papers here. We can get them for you too. If you find things you want to read, let us know. We'll pull them from university libraries for you. Most of us are either still affiliated with universities or recent students, so we can pull those papers for you. So, thanks for your attention, guys. Any questions or things I can unpack for you? Yeah, Rachel.
So for a geriatric population,
Yeah.
particularly even in a residential care setting, what if you could do neurofeedback in that setting? What benefits might you expect?
If we ignore specific features of aging for a second and talk about broad categories, what will happen for most people is we'll get 2 things. One is speed of processing will improve. Speed of processing is among the biggest bottlenecks in human performance, other than being working memory. Speed of processing slows down with aging. Working memory doesn't really degrade much with aging, so you notice the speed of processing as a word finding, short-term memory issue. Another big thing that happens with aging is the sleep architecture changes. People move from a biphasic sleep pattern back into like a baby sleep pattern, sleeping with chunks of random waves. And the REM goes down and slow wave sleep goes way down. So with training, you can speed the alpha back up, eliminate the word finding problems, and you can improve the sleep architecture back to a typical architecture, where you're going to bed for 6 to 8 hours and sleeping for most of that time, and waking up refreshed. That's the easy stuff. And then individuals may have stroke damage or language issues or anxiety because they're socially isolated, or pain, chronic pain. There's a pain circuit in the ventral area. You can actually train down the pain circuit and reduce the experience of pain. It works really well in this chronic pain, i.e. central pain, being echoed by the brain from a peripheral thing that's constant. The brain will pick it up and echo it over time. It becomes a brain phenomena. You can really reliably dial that down for people that have that chronic pain. And those are all relevant for elders. Also, alpha theta brings up T cells in a measurable way. So if elders are having compromised immune systems, you can bring up CD4 plus cells dramatically with alpha theta neurofeedback. So again, every person's an individual, so I'm sure that some of these elders also have ADHD, anxiety, a little trauma history, some slowed processing from concussions. All those things go away too. But it has to be tailored to the individual, and that's why the research is a little bit, about the category, which is not quite as good. So, but yeah, a brighter brain essentially. That's what you would say. Like sharper, crisper, better sleep, better awareness, etc. Sir.
So, can you improve motor function?
Yeah, I work with a lot of athletes, a couple of Olympic athletes right now, as well as some triathlons, and they have better athletic performance. Some of it's actually controlling your body better, noticing your body better. I think a lot of it for these guys, especially the really high-level guys, is getting out of the anxiety state of performance, like dropping into the zone more reliably. I'm working with a couple of track and field guys right now. One's a pretty high-end Olympic guy, and he's noticing he's actually able to relax more fully in the blocks before releasing. And for him, that means he's actually ahead of the next guy over when the gun goes off, instead of like relaxing and then leaping because he's in stress.
So what about brain trauma as a result of an accident?
Sure.
That's impacted motor function?
Absolutely, but we have to work on it longer. If it's tuning existing tissue, it's 3 or 4 months for a really big change. If it's injuries, damaged tissue, it might take up to 6 months to make it really permanently change.
And the brain can impact that? Can impact the tissue?
Sure, we can
reformation?
rebuild tissue. I mean, I've never documented it in neuroimaging, but you can see the massive change in performance. So, the brain has an infinite amount of processing power. I mean, effectively infinite, anyways. We have way more than we need. We have effectively infinite storage capacity. The estimated storage capacity of the brain is larger than the atoms in the universe. Because of storage, there's many ways memory gets created. One of them is synapses. Right? Two cells talking to each other. You can create or not create a synapse, create a stronger synapse. And the information density of the brain, ignoring all of the multiple recurrent connections and multiple types of cells, just considering neurons, the bit density, the number of synapses you can create is the number of neurons raised to the power of the number of neurons. So
100 billion times.
100 billion to 100 billion. That number is larger than the estimate of atoms in the universe. You can store more stuff than there is stuff. So there's never any issue with running out of storage capacity. At this point where I tell my students they have to now get perfect scores on the exams. But the brain can reorganize. Like there was a case study last year showing a guy in the UK who had like 5% of his brain tissue left, just edges of it wrapping the edges of his skull through a normal pressure hydrocephalus in a coma for 30 years, woke up intact. And the tissue had developed this incredible density that was not normal, like recurrent connections that were like 30 times more dense than is typical in the cortex. But this is one of the things the brain can do. So am I rebuilding a damaged bit of tissue or building around it? I don't know. But massive shifts in spasticity, seizure, other major brain things go away.
So doing this while they were in a coma?
Yeah, you can do this in a coma, sure. You don't have to be awake. Margaret Ayers, one of the greats in the field who died a couple years ago, her whole job was going to coma bedsides and doing neurofeedback to bring people out of coma. That was her whole job. After a while, she developed this special technique to do it and special software to do it. So yeah, you can bring people out of coma, you can do work on concussion, you can work on TBIs.
Vision?
You can increase plasticity, but vision's a pretty complex phenomenon, a complex system, and it often has pretty locked in what are called critical periods, where it's hard to change vision after age 6 months of development. So you can change a little bit. Like people often, after doing ADHD work, come running back into the office like week 2, week 3. I'm seeing better. Well, you're actually attending. No, I'm seeing better. Oh, okay. Like they walk out and notice like the windshield wiper fairies crept in. They're like, wow, the world's really crisp and clear and bright, and they think they're seeing better, but they're not. Just the gain back here was cranked up a little bit, and so they're attending differently. So you have perceptual differences, but they're not dramatic, And I wouldn't expect to affect the function of the eye or dramatically affect the function of the visual cortex, because that's a system that's pretty locked down after about age 6 months. But other things are really changeable. Most
But
other
even
parts.
if it's trauma associated with trauma from an auto accident or something?
Oh yeah, sure. Yeah, I know a lot of
Even then it's locked down and
Well, no, but I'm saying the brain is not locked down, period. The visual system's organization is, so it's hard to reorganize. But you can add like plasticity to the whole brain and get shifts in some things. If it used to work and doesn't after the accident, chance to be much, much better to regain it.
okay.
Like I have a friend who had a strabismus where I was off to one side. She had surgically corrected at age 30, which you shouldn't do. Now you do it when you're first born, because the plasticity, the visual system, it does visual fusion. You can't learn that really after age 6 months. And so she did this, and she then saw double for the rest of her life and a drop out of her grad program because she couldn't read anymore. That is not something I would be able to help, probably. But you used to see fine, you have acceptable area injury, you can't quite process well, you get fatigued by screens, you can't do visual fusion without fatiguing. That, I'm sure I can help. Just help them rebuild the stuff that was there. That's easy. Might take a while. Might have to hunt and peck and lean on your brain kind of hard, but I'm not concerned about trying to find something there. But taking a system that's pretty well set and reach and changing it, that I don't think I can do.
And negative side effects?
Yeah, some. But it's like working out.
To this treatment.
Yeah, it happens. But it's like working out. You work out too hard and you're wiped out. You work out the wrong way and you can't move the next day. So with neurofeedback,
So everything's short term.
it's very short term. It's also very informative. We train your left side beta up and you're like, oh my God, I left here. I was on, I was getting all this work done and I couldn't fall asleep. I was like up for like an hour. Like lying there, like my mind was busy. Oh, okay, we pushed a little hard, let's back off today. Or I walked out of here and I was just wiped out. I couldn't quite get my energy back. We overtrained you, let's just back off today. Or wow, I walked out of here, I felt great, powerful, slept well, woke up cleanly. Repeat that. See, oh, it happened again? Happened again? Okay, now we're on to something. So we don't believe especially all the subtle things you experience day to day are from the neurofeedback, but if they start to trend in a certain direction, we get excited. And then if we map your brain again 7 weeks later, and the trends have continued, and they show up in the brain data as well as in your subjective experiences, now we believe it. Or start to believe it anyways. But yeah, you can just kind of go after things almost like you're saying to the personal trainer, I want abs. All right, let's go after abs for you. So.
We have a user here asking how we compare to brain balance.
Brain balance is one of the one-size-fits-all systems that's a bit sort of software-driven, where it picks protocols for you, and it's usually done by semi-skilled clinicians who aren't neuroscientists. But half the systems out there in neurofeedback are one-size-fits-all systems or have special stuff built in that people think are magic. And the other half of the field uses science and maps the brain, tailors the process to you, is very critical, doesn't believe very much, but digs in a lot. So if you work with someone who thinks they know what's true about the brain, you probably should run away screaming. Because we don't understand the brain. It's a phenomenon we manage, not something we deeply understand. And so I'm opposed to all the one-size-fits-all system. I think unless you're doing QEEG brain mapping to tailor the process to your brain, you're getting, at the best, less than optimal results. And at worst, you might be creating side effects, or not getting permanent, or not getting any effects. That can happen if you're in the wrong way. So yeah, I think QEEG is the evidence-based threshold for neurofeedback. Not the only way that it works, but you should be pretty confident if somebody's doing QEEG, they've invested in the expensive and sophisticated evidence-based side of the field and haven't bought some multi-level marketing program that is all about marketing language. And not that brain balance is, there are some other systems out there that are all about marketing, and you can kind of tell if you dig in. Anything with the word quantum in it, run away. It doesn't exist. Quantum outside of a physics context is nonsensical. So is the word detox outside of a very specific context. You can't detox your system any faster than it detoxes itself, unless it's alcohol or drugs. But you can't do detoxing or quantum anything, so a little side effect, side tangent here. So, other questions I can answer to you guys, or things I can unpack a little more? Well, thank you so much for coming. So again, we have free mindfulness classes with Sean on Mondays. We have free brain talks at least once a month. I think the next one is in about a month, and we're doing it on subtyping ADHD versus anxiety, so you can distinguish the two using brain mapping. This might be useful for a clinical population because a lot of my clinician colleagues will send clients to get maps so they can help understand the client's brain better. Because it doesn't really make a lot of sense working on the person's anxiety if it's really ADHD, for instance, or doing cognitive behavioral therapy for ADHD. It's not a cognitive problem, it's a wiring problem. You're never gonna do scaffolding, do coaching for ADHD, not therapy, right? So sometimes people want to distinguish those two things. So we're going to do that a little bit and show you some of the same data, but we'll really frame all the anxiety markers against all the different subtypes of ADHD: inattentive, combined, oppositional with anxiety, those sorts of things. So there's at least a handful of 3 or 4 different subtypes within anxiety, within ADHD that are pretty clear and can help you understand what's happening. And of course, these things can occur in the same person at the same time. Yeah, in fact, ADHD often comes with lots of other things, right? So we'll tease apart which of these things is operating for you can be very empowering. Oh, it's my brain. That's why I'm impulsive or ruminating. Oh, okay. So we like to help people understand themselves.